Perfect. Well, good morning, everyone. Welcome to the first grand rounds of the new academic year, and that means that this is the first grand rounds for many of our interns as well as our new fellows, so welcome. It is a pleasure this morning to introduce Dr. Pervez Sultan and his team as they present Anesthesia and Postpartum Recovery, New Frontiers and Opportunities. Dr. Sultan is a professor of obstetric anesthesiology at Stanford and an honorary professor at the University College London in the Department of Targeted Intervention. He's an NIH-funded researcher with more than 170 peer-reviewed publications with research interests that include defining, characterizing, measuring, and improving postpartum recovery. Among other work, he serves as the PI on an R01-funded grant to develop and validate a new PROMIS measure of postpartum sleep. Dr. Sultan has been recognized widely for his work, being chosen to give the prestigious Ostheimer Lecture at the 2023 Sept annual meeting. He was elected to the Association of University Anesthesiologists and serves on national boards for academic practice and research. And presenting with him today are two trainees. First, Dr. Philip Callahan is an obstetric anesthesia fellow at Stanford, who we are very pleased will join faculty this coming January. Dr. Callahan completed his anesthesia residency at the University of Virginia and previously served in the United States Navy. Dr. Moe Takenoshita is a physician from the UK, currently working toward a PhD under Dr. Sultan in measuring and optimizing outpatient postpartum recovery. On a personal note, these physicians and really the entire obstetric anesthesia team are the ones you want across the curtain during an obstetric emergency. They're also driving clinical improvement for pregnant and postpartum populations, as you'll hear about today, and we are so lucky to have them as partners in our care. So please remember today to put your questions in Q&A, and I'll moderate those at the end. And with that said, Dr. Sultan.
Thank you, Deirdre, for a lovely introduction and the opportunity to speak at these grand rounds. It's something that's been on my radar for wanting to do for quite a while now. So I've fulfilled my dream. And I hope it's helpful. So today I'm going to be covering some of the new frontiers and opportunities that are related to obstetric anesthesia and postpartum recovery. So there's clearly a lot of overlap between anesthesia and obstetrics in this regard. I've got no relevant conflicts of interest to declare. So we've got a lot to cover in the next 50 minutes or so, and I've divided my talk into three parts. So first of all, I'm going to focus on some intraoperative aspects of cesarean delivery, and there's a really hot topic at the moment surrounding intraoperative pain during cesarean delivery. So I'm going to give you some of the study findings for a study which is kind of just about to be published. So you're getting the inside scoop surrounding intraoperative pain. And then Dr. Callahan is going to present some of his hot off the press findings regarding qualitative findings from LPCH for patients that actually experience pain. Next, I'm going to talk a little bit about inpatient postpartum recovery, focusing on the latest ERA Society enhanced recovery guidelines that have just been published in the American Journal of Obstetrics and Gynecology. And then I'm going to talk to you about how to measure quality of recovery using a novel measurement strategy, which we've recently introduced to LPCH, called the Obstetric Quality of Recovery 10-item scoring tool. And then I'm going to summarize a core outcome set of measures that we can use to evaluate our enhanced recovery protocols. And then finally, we're going to pivot to outpatient postpartum recovery, and I'm going to present with Dr. Takenoshita about the Stanford Obstetric Recovery Checklist, and then I'm going to talk a little bit about PTSD after childbirth and the measurement of postpartum sleep. So let's start with intraoperative breakthrough pain during cesarean delivery. We all know that neuraxial anesthesia is the gold standard and is preferred to general anesthesia. And this is based on decades worth of work, which has demonstrated better neonatal and maternal outcomes associated with the use of spinal and epidural during C-section. It reduces maternal aspiration and also is associated with better recovery outcomes, including pain outcomes, nausea, vomiting, pruritus, improved patient satisfaction. And it means that the partner can be there during the delivery, in addition to skin contact and early breastfeeding. This is obviously very well in the literature, and that's why we do what we do. However, if anyone has had the chance to listen to this podcast, which is a New York Times podcast called The Retrievals, it's an entire 4 episodes about intraoperative pain experiences during cesarean delivery. And I was actually interviewed as part of this, and they quote our study as well. So definitely worth listening to. And actually in 2022, the American Society of Anesthesiologists stated that intraoperative pain should be measured as a quality metric during cesarean delivery. So it's a really hot topic. And that's why it prompted us to do some research in this area. So in 2022, we published this massive systematic review with the aim of determining the prevalence of inadequate anesthesia. So we just looked at randomized controlled trials in patients that had adequate doses of spinal or epidural drugs. And we looked just at elective cases. So this does not include intrapartum cesarean deliveries. And from the data that we found, there was 54 randomized controlled trials, nearly 3,500 patients. So this is a high quality set of data with a low risk of bias. And what we found was, rather surprisingly, is that inadequate anesthesia, defined as any supplemental analgesia or requirement for GA, occurs in around 15%. So that's not an insignificant number. General anesthesia in this elective setting is reassuringly low at 0.06%. The other interesting finding as well was that if you had an epidural top-up, which used to be the mode of anesthesia decades ago when some of the earlier studies were done, then actually your rate of inadequate anesthesia is 3 times higher than if you just have a CSE or a spinal technique, so 10% versus 30%. We kind of already knew that epidurals aren't as good as spinals and CSEs, but this is a really good data set with good high quality data supporting this. But this also led to some important questions of, well, what is inadequate anesthesia? It's not enough just looking at the number of patients that need analgesia, but maybe we need a more patient-centric outcome. And how can we best manage this complication? And importantly, what are the long-term psychological sequelae of this feared complication? So this is data that we are just about to publish in anesthesiology, where we aim to perform a multi-center study prospectively looking at patient experiences of intraoperative pain. So the primary aim of this study was to get a prevalence of intraoperative pain by asking patients day 1 or 2 after their cesarean delivery. We excluded patients that weren't able to report and if the pain was not intraoperative, but we included patients across 15 US centers over a 8-week period. And over this period, everyone that delivered by C-section were asked these 3 questions. Number 1, did you experience any pain during your C-section yesterday or the day before? Number 2, how would you rate your worst pain from a 0 to 10? And then the last one is, if you experience pain, were you satisfied with the anesthesiology management of your pain? For patients that were willing to take part in a consenting part of the study next, were invited to ask questions or answer questions regarding their pain in terms of characterizing it and mapping it so we can get a better idea of what they actually experienced. So here is data from nearly 3,700 patients across 15 sites. You can see that there's a pretty good spread of patients in terms of race and ethnicity. It's pretty representative with about 20% Black patients, about a quarter of patients who were Hispanic. And we had a lot of different spoken languages. About 20% were non-English speaking. So iPad interpreters, etc., were used as part of this study. As we'd expect, the majority of these patients actually had either urgent or emergent cesarean delivery, with about 44% of patients having scheduled or elective. The take-home message from this is that the overall incidence in this cohort, which is a pretty representative sample of the US population, is about 7.6%. And if we break down the results a bit further, we actually did unadjusted and adjusted models to identify variables which were independently associated with patients experiencing intraoperative pain. And interestingly, Spanish language was one thing that came out with as a significant variable. And the other things were epidural top-up, which we were expecting, but also CSC. And this is an interesting one because if we actually think about which patients get a CSC, these are patients where we're anticipating there's going to be longer surgery. So it may end up with the fact that we have to use the epidural, which is not as good. And also we end up doing CSCs in patients with complicated backs where there's probably going to be a higher failure rate of our neuraxial technique. So this is just something to bear in mind. And this may encourage us, to try and think about our anesthesia technique in a bit more depth prior to surgery. In terms of medications given for intraoperative pain, there's a wide variety because there are no guidelines surrounding what we should give. The majority of patients get fentanyl in this cohort, but there's patients also that get dexmedetomidine, propofol, ketamine, and nitrous oxide to breathe. Interestingly, about 20% of patients got midazolam, which is important because midazolam isn't an analgesic, but it's an anxiolytic. So if you're treating pain with an anxiolytic, then that's not entirely appropriate unless you are also co-administering an analgesic at the same time. The other important things that we took away from this study was that of the patients that experienced pain, about 16% had a conversion to general anesthesia, and documentation was generally poor across the institutions, with nearly 60% of the cases not having pain documented. And that's really important because actually in the UK, the most common reason for an anesthesiologist to be sued is actually for poor management of intraoperative pain during cesarean delivery. When we actually consented the patients to take part in round 2 of this paper, we actually asked the patients to map where their pain was worse. And it's really interesting that you can see on this heat map that there tends to be worse pain on the right, which may actually be attributable to the fact that we tilt our patients and do left uterine displacement. Obviously, we know that our spinal drugs are affected by gravity, so there tends to be actually better pain relief on the left and more pain experienced on the right. In terms of pain intensity, overall in this cohort, it was 6 out of 10, which is by definition moderate pain. But in the patients that had urgent cesarean delivery, it was 7 out of 10. So that's a severe pain experience by definition. A quarter of these patients described their experience as distressing. And amongst the patients who actually had pain, 10% were dissatisfied with the anesthesia management. And dissatisfaction was actually associated with higher pain scores, intrapartum cesarean delivery, and patients of black race. So next I'm going to get Dr. Callahan to talk a little bit about his work surrounding describing pain.
All right, good morning, everyone. So I'm going to speak briefly about a study that we recently published focusing on the qualitative patient experience of pain during cesarean delivery. So studies surrounding patient experiences of this unfortunate complication are lacking. And so the primary outcome of our study was to identify themes that describe experiences of pain during cesarean delivery performed under neuraxial anesthesia. This was a prospective qualitative study that we conducted using semi-structured interviews with 10 patients who experienced pain during cesarean delivery. And the way that these patients were identified during postpartum rounds, we asked, did you experience pain during your surgery, yes or no? And so these patients all said yes to that particular question. There's a word cloud on this slide that depicts the 100 most frequently used words during these interviews, which gives you an idea of what these patients were focusing on from this experience. The results of the study, we identified 9 domains and 76 subdomains for the construct of pain during cesarean delivery. Those domains include maternal psychological state, anesthesia care in the OR, patient expectations, sensations during surgery, patient impression of the anesthesia provider, interactions with staff, anesthesia care on labor and delivery, obstetric variables, and testing the block. And I want to focus on a few patient quotes from domains that are very relevant to what we're speaking about today. So number one would be patient expectations. So our patient said things like, the whole experience was really bizarre, just having surgery while you're awake. I expected that I wouldn't feel anything. Rare things can happen too, so I've just learned to accept that anything can happen. It was just painful, and that wasn't what I was expecting. And so this really highlights the importance of setting expectations for our patients before going into surgery. The second domain I'd like to focus on is anesthesia care in the OR. And then the OR felt like complete chaos. This was a patient who experienced an intrapartum cesarean delivery, and I think we've all experienced the chaos is the perfect word for it that can occur when we're rushing quickly to the OR. I think that's very normal for our teams and we're used to it, but just thinking about it from that patient perspective and how potentially traumatizing that can be. And then maternal psychological state, I wanted to be alive when she was born. So there was a recurring theme of survival when speaking to these patients and willing to tolerate things that almost no one could possibly endure, focusing on their survival and the survival of the newborn. Other quotes I really would like to share with you all, these are specific to the pain experience and descriptions of the pain. Like ripping and then like kind of scraping. I could feel like the sharp spasms. It wasn't just an emotion. Like they're literally cutting me open and I can feel it. It's all tugging and pushing. They did say, oh, you'll just feel pressure, but there's definitely things in between that you can feel. So I feel like people might get consumed and keep quiet until after they feel that sharp pain. And I think it's better to speak up sooner rather than later. I need you to stop. I can't keep going. I can't handle it. So these are very impactful quotes from patients who have experienced a major abdominal surgery while they're wide awake. And these quotes can be pretty meaningful and honestly, they hit pretty hard. I think it really highlights that this is a major problem and that we need to not only set expectations, but we also need to create an environment where we are inviting the patient to speak to us about anything that's bothering them from the very start. And so there's a couple of resources that can help us to do this. And so I wanted to go through those, and I believe we'll be providing this particular toolkit, which was published by the Society of Obstetric Anesthesia and Perinatology. It's for providers to help with expectation setting and guidance. And so I've provided a couple of examples here of the type of information that this will give you. So how might you respond if a patient asks how common is pain during cesarean? As far as responses, setting the goal for you to stay comfortable during the surgery, you will likely feel sensations that some people describe as stretching, pushing, pulling, pressure. And if those sensations become uncomfortable, please let us know so we can immediately address it. And then why do some patients experience intracesarean pain? We want to focus on validating and supporting patients with pain. And doing that is protective against the negative effects of the pain experience. And then it's very important not to spend time debating whether it's pain versus pressure. And so this is a very useful tool, and we'd be happy to provide that for everyone. And then there's a patient-facing resource as well, the Painless Push website, Anesthesia for Your Cesarean Delivery. And again, this highlights some of the common sensations and experiences that are important for expectation setting. So it's common to feel sensations such as touch, movement, pressure, tugging, or pulling sensations during the surgery. Though these are not uncomfortable for most people, they can be for some. So it's very important to set that expectation for the patient and also invite them to let us know if there's anything uncomfortable. So there are certain times where you will feel a lot of pressure on your belly and below your ribs, usually when the baby is being delivered. And if this feeling becomes intolerable, it is important to let the anesthesia team know so that they can help. And so these are examples of the types of quotes and information that you can give to patients from this particular resource. And so overall, these are traumatic birth experiences, and future studies are needed to determine the optimal treatment and the psychological sequelae of these particular experiences. And so that's something that I'm working on right now. Thanks for having me.
Great. Thank you, Dr. Callahan, for that really impactful work. And I'm sure there'll be lots of people wanting to ask questions and discuss this important topic, considering that these quotes were taken from patients delivering at our very own institution. Okay, so next I'm going to pivot a little bit away from intraoperative pain, but focusing on overall postpartum recovery. And I'm going to focus firstly on enhanced recovery. So enhanced recovery is a set of bundled interventions where we are trying to reduce variability and deliver evidence-based practices in order to reduce complications, improve patient experience and satisfaction. So I had the privilege of having a glass of wine with Professor Henrik Kellett, who you may not have heard of, but actually he's the godfather of enhanced recovery, and he actually published the first ever enhanced recovery study in the Lancet in 1995 regarding colorectal surgical patients. So they were definitely the innovators. And we, unfortunately, are the laggards. The first reports of enhanced recovery weren't actually published in the obstetric domain until 18 years later. But I'm happy to say that we are now innovating the field in many ways. And we'll talk about that a little bit later on. So why was there a need for an update to the Enhanced Recovery After Surgery Society guidelines? The original ones in the first row here were published in 2018 and 2019, but they looked at just the obstetric and anesthesiology perspectives. So they neglected to include stakeholders from nurses and the patient representatives as well. In addition to this, the original ERAS Society guidelines were just from a UK anesthesiology perspective. So SOAP actually tried to address this in 2021 by publishing their consensus statement from the US anesthesiologist perspective. And more recently, there's been the Healthcare Canada pathway, which is actually really good, but it's obviously from a Canadian perspective. So from the pre-existing guidelines, there was a lack of US specific guidelines, and there was lack of representation from all the different diverse groups of specialties. And importantly, it lacked stakeholders from key professional societies, including lactation consultants and physical therapists as well. So we tried to address this by updating the ERAS Society guidelines, and we performed a modified 3-round Delphi approach with stakeholders from 8 different professional societies, including the Anesthesiology and ERAS Society stakeholders. We also include representatives from the Obstetric and Gynecology Societies, SMFM, and the nursing societies as well. We included patient representatives, a lactation consultant, and a physical therapist to try and address the gaps of previous guidelines. The 3 ERAS Society papers are now published online, and they will be published in the AJOG cesarean supplement, which should be published soon. But in the end, we advised 32 different interventions, and there are 6 preoperative, 13 intraoperative, and 13 postoperative interventions. It's beyond the scope of this talk today to go into a lot of detail about these, because we actually do these very well at Stanford, but it's just to highlight the importance of some of these initiatives. So the preoperative interventions, broadly speaking, can be divided into nutrition. In other words, limit your fasting times, try and do carbohydrate loading 2 hours before surgery, educate patients and also staff. So staff education wasn't included in previous iterations of guidelines, and prepare patients for lactation and breastfeeding, and try and optimize comorbidities, including anemia and glucose control, and also try and get patients to stop smoking before their delivery and exercise adequately as well. In terms of the intraoperative interventions, these are supported by lots of evidence, but the main themes here are to prevent and treat spinal hypotension with the use of a crystalloid co-load with a variable rate phenylephrine infusion, which we do at Stanford. We should warm all of our patients in the absence of contraindications, and we should be giving 2 antiemetics in the absence of contraindications as well. We should be optimally dosing our uterotonics, and there's a suggested algorithm which has been published in the second paper. We obviously want to give antibiotics to all of our patients prior to surgery, and then we want to start a multimodal analgesia regimen within the OR. So if the patient doesn't have any contraindications, we should be giving long-acting opioids in the epidural or spinal space in the form of morphine to all of our patients. In terms of post-operative interventions, we should be trying to get our patients dreaming, in other words, drinking, eating adequately, analgesed and mobilizing and supporting their breastfeeding needs as well. So I'm happy to say that we do all of these things at Stanford really well, but there's always room for improvement. And one way that we can improve is by benchmarking our practice. The evidence surrounding enhanced recovery after cesarean delivery protocols is summarized in this meta-analysis that we published a few years ago. So this looked at data from nearly 17,700 patients, and this was about across 12 studies, where the majority of them are actually before versus after impact studies, with 3 randomized controlled trials out of the 12. And the primary outcome for this study was length of hospital stay, which was significantly reduced by half a day with the introduction of enhanced recovery protocols. There was also a clinically significant reduction in times till first mobilization and urinary catheter removal, reduced by 11 and 13 hours respectively. Opioid consumption was reduced by 22 milligrams of morphine equivalents in patients that had enhanced recovery protocols, and cost savings was demonstrated in 3 studies, but there was differences in study design, so that data couldn't be pooled. Importantly, there was no difference in maternal readmission or reattendance. But because the majority of these studies are not randomized controlled trials, the evidence surrounding enhanced recovery is considered low or very low when the evidence is graded. And there's a lot of heterogeneity in the interventions that are delivered to patients and the outcomes used to assess the patients as well. But because there is a low risk of harm and a high chance of benefit, in the latest ERAS Society guidelines, most of the interventions are supported with strong recommendations. But what we really need is a way of improving the levels of evidence surrounding enhanced recovery after cesarean delivery. So an aspiration of mine is to actually do a very large multi-center cluster randomization study, maybe even across California using the CMQCC, where we can really get to grips with how good enhanced recovery is and improve the levels of evidence at a state level. I mentioned benchmarking our practice before, and one way that we can do this is by using patient-reported outcome measures. So a PROM is a survey instrument which is able to evaluate multiple domains or dimensions of health. They are considered the gold standard for measuring post-operative and postpartum recovery, and they're really good for quality improvement. So by using PROMs, we can actually see which anesthesiologists have the best outcomes in terms of their patients' recovery, but also we can also see which surgeons have the best outcomes as well. And on a bigger level, we can see which institutions have patients that recover better than others. And we can do this to pat ourselves on the back when we're doing well, but also identify areas where we could improve on. And in the UK, PROMs are actually used to incentivize hospitals, so they base financial return and repayment and reimbursement on how patients report PROMs 6 weeks after big operations such as knee and hip arthroplasty, varicose vein surgery, and inguinal hernia repair. So this may be something that we start seeing used in obstetrics as well in the future. I want to take a few minutes to talk about the obstetric quality of recovery 10-item scoring tool, which is the best measure of inpatient recovery that we have. I actually developed this measure when I was in London before I moved back to Stanford. And we started off by looking at the QOR40, which is a really good inpatient metric for patients that have had inpatient day surgery. So we took away any general anesthesia related items, added in spinal and epidural related items, and added some items related to having a baby and obstetric items. And what we came with, the 10 items that correlated best with the patient's recovery following childbirth, are as follows. So there's the first 4 are regarding pain, nausea, vomiting, dizziness, and shivering, and the last 6 are surrounding feeling comfortable, ability to mobilize independently, ability to hold the baby, feed the baby, look after personal hygiene, and feeling in control. So if a patient fills this out, they will, at 24 hours plus or minus 6, fill this out. And for this particular example, you can see the patient actually has a low pain score, doesn't have nausea, vomiting, dizziness, or shivering, but actually they're not performing so well in terms of feeling able to mobilize. They're not able to hold the baby, nurse the baby, and they're not able to look after personal hygiene and feeling control. So basically, it gives you a score out of 100, where 100 is the best possible recovery and 0 is the worst imaginable recovery. And based on this, we've actually recently implemented this at Stanford, where everyone who delivers after any delivery mode will have this assessed at 24 hours plus or minus 6. And team anesthesia will now be called to review any patient with a score of less than 65, because this is a value which has been identified in multiple studies to be associated with worse inpatient recovery, but also worse outpatient recovery. In fact, these OBS-QOR scores at 24 hours are correlated with depression scores at 6 weeks as well. So we really need to work as a team to get team anesthesia, OB, lactation, nursing, and psych input to the patients to address where they're not performing so well. So here's a little bit about the evidence supporting the use of the obstetric quality of recovery scoring tool. These are just studies done in the UK and the USA, and OBS-QOR actually correlates with quality of recovery as assessed by the patient. It also correlates with hospital length of stay, estimated blood loss, antiemetic utilization. And as we would expect, patients that have an emergency C-section have worse recovery scores compared to an elective C-section, and patients that have an operative vaginal delivery and episiotomy have worse recovery scores compared to a normal vaginal delivery. We've now validated this around the world. These have all been published studies in 10 different languages. So it's definitely representative and it's generalizable across all populations. It's the best measure that we have, and we really should be using it. In Japan, it was quite a nice study population, because after delivery, most patients stay between 5 and 7 days after their cesarean delivery or vaginal delivery. So we can actually start to get longitudinal quantitative data about recovery. And from this cohort, we can see that after a cesarean delivery, there's a plateau around day 3 in terms of recovery scores. And after a vaginal delivery, there's a plateau around day 2. So there's significantly better recovery in the first couple of days after vaginal delivery, and then the difference becomes less marked when comparing OBS-QOR scores. We actually did a 107 center, multi-center study in the United Kingdom, where we looked at national OBS-QOR scores in around 1,700 patients over a 2-week period. What we found in this cohort was that patients that had longer lengths of stay had worse OBS-QOR scores, and patients that had readmissions in the first 30 days or complications in the first 30 days after delivery tended to have worse 24-hour OBS-QOR scores as well. So further evidence supporting the potential clinical utility of this tool. Now, we've talked about what interventions we should be using for enhanced recovery, but there wasn't until recently consensus regarding how we should assess how good our enhanced recovery protocols are. So this was a Delphi study involving 32 different stakeholders who were experts from multiple specialties, and also we included patient representatives. And in the end, these are the 15 metrics that we recommend should be measured routinely in hospitals in order to evaluate enhanced recovery protocol success. And what we would ideally have is a dashboard where we can see on a monthly or quarterly basis how we are performing in all of these metrics. Now, many of these seem very obvious, but I think it's important that we should be measuring all of these on a regular basis. And importantly, highlighted below, the obstetric quality of recovery multidimensional measure is the only composite score that was included in this core outcome set. So the final part of my talk, I want to focus on outpatient postpartum recovery. There's actually been a disproportionate amount of effort spent on inpatient recovery. And we all know that the majority of a patient's recovery experience actually happens after they leave the hospital. And it's important because there's a big knowledge gap here. We know that there's high maternal mortality rates in the US, and these are disproportionately high compared to other high income countries. And most maternal deaths, according to CDC data in the US, actually happen after day 7 when the patient is at home. And suicide is a leading cause of postpartum mortality. So anything we can do to improve outpatient recovery experience may have a positive impact on depression, suicide, and other maternal morbidity and mortality. This is data published from Sarah Cicanovich, who was here last year at Stanford. And what she wanted to do was to look at chronic pain after cesarean delivery. So this is a really big systematic review and meta-analysis that she did, looking at data from over 13,000 patients and 50 studies. There was an incidence of around 17% of pain between 3 to 6 months. So that by definition is chronic pain, and 9% prevalence of severe pain between 3 and 6 months. And this reduced after 6 and 12 months. But even at 12 months, there was still 9% of patients endorsing ongoing pain. And one of the important conclusions from Sarah's study was that 1 in 10 patients experience chronic post-surgical pain after cesarean delivery that interferes with daily life, work, social life, and personal care. On the back of this data, we are now undertaking 2 studies at Stanford. The first one, we're actually trying to recruit patients at the outpatient follow-up clinic at the 6-week time point. And we are, Dr. Jethwar, who is another one of my postdocs, is going to be offering patients cognitive behavioral therapy for patients who have ongoing pain to see if it reduces pain at the 12-week mark. The second study is that we're going to be recruiting patients before their cesarean delivery and offering them and teaching them cognitive behavioral therapy strategies for managing their pain, along with other multimodal education videos to see if that improves overall recovery and pain outcomes. Now, recovery is a really important metric, and this study done by Brendan Cavallo and Pamela Flood really hits home how much of an issue recovery is, because in this study, patients were invited and called up every day after their delivery and asked 3 questions. Are you still in pain? Are you still requiring painkillers? And have you recovered from your childbirth? And here is a survival curve demonstrating that by week 6, 10% of patients who have had a cesarean delivery are not recovered after their delivery. And 5% of patients who have had a vaginal delivery are similarly not recovered. So this is a potential public health issue which is not currently being adequately addressed. So let's focus a little bit about outpatient recovery. When I first came to Stanford, I really wanted to get to the bottom of what is postpartum recovery. So I did 24 hours worth of interviews with patients and experts, and this is a word cloud analysis of those spoken and transcribed interviews. And you can see there's a lot of different things going on, but the conclusion of our first paper was that recovery can broadly be characterized by 13 different domains. These include physical function, surgical complications, cognition, psychosocial distress, which includes anxiety, depression, PTSD, and other psychological morbidity, infant health, pain, psychosocial support, motherhood experience, which includes adapting to the maternal role and maternal neonatal bonding, feeding and breast health, sleep, fatigue, sexual function, appearance, and cosmetic. So this is a really good starting point, but there's also a lot of work still to do because we actually don't know how these change at different time points and how these different domains are interrelated as well. And what we really wanted to get to the bottom of was how can we best measure each of these different domains? And the way that we can do that is by performing a systematic review, first of all, to identify what measures have been used. And then we can use something called the Cosmin criteria to really get to the nitty-gritty of how good is that survey instrument for what you're using it for. So this is a 78-page document. And for anyone thinking that using surveys is a fluffy science, I'll hopefully persuade you that it is an absolute, it's quite a complicated science, as demonstrated by this slide. This could be an hour lecture by itself, but when you're assessing how good a survey instrument is, broadly speaking, you look at three things. Is it valid? In other words, does it measure what you want it to measure? Is it reliable? In other words, is it reproducible? And is it responsive? Can it measure a difference in the constructs over time? In other words, if a patient's improving, will your measure show that? And similarly, if the patient's getting worse, will your measure show that? And then there's lots of different things that you can look at within how good a survey instrument is. And this is called psychometric analysis of a survey instrument. So it's beyond the scope of this talk, but rest assured, this is a detailed science. When we apply the Cosmin criteria to inpatient recovery metrics, the obstetric quality of recovery scoring tool is recognized as the best current available measure of not just C-section, but actually all inpatient recovery. So it can be used after any delivery mode. The next thing that I did was started to look at outpatient recovery measures. And this was a massive scoping review where we screened over 8,000 articles. And in this review, we identified 200 patient-reported outcome measures, which look at least one aspect of recovery. And there were 15 measures that looked at more than three measures. So those could be regarded as global metrics. And the next thing that we're going to do, and the conclusion from this is that the World Health Organization quality of life score was actually identified as the best available measure, but this measure was not developed for postpartum patients. So it doesn't ask any questions about postpartum depression. It doesn't ask any questions about the baby, maternal neonatal bonding, breastfeeding. These are really important things that were neglected. So we sought to develop an outpatient recovery metric, which Dr. Takanishita is going to talk about next.
Morning, everyone. Hi, I'm Moa. So, as Pervez described, to address this gap, we developed the Stanford Obstetric Recovery Checklist, or STORC, in order to comprehensively evaluate postpartum recovery in the outpatient setting. So STORC was developed using PROMISE methodology, which is a NIH-funded, rigorous methodology that involves literature review, focus groups, and interviews to develop PROMs for mental and physical health, as well as social well-being for adults and children. The stakeholders involved in this process in our study included experts across diverse specialties and patient and partner representatives. Delphi method was used, which is an iterative process of developing a list from existing questions through feedback, discussions, voting, and scoring. And after 3 rounds, these questions were piloted among 10 patients who were then interviewed to assess the interpretability, understanding, and the wording of the questions. The final measure included 47 questions, which were each scored out of 4, giving a maximum possible total score of 188 and a minimum score of 0. A higher score indicates better recovery. The questions covered all domains of postpartum recovery, namely physical recovery, mental and emotional well-being, social support and motherhood experience, and sleep and fatigue. We then carried out a multi-center longitudinal cohort study to validate STORC and to characterize longitudinal postpartum recovery using STORC. We also aim to profile recovery for each of the 4 domains, and we also want to compare recovery between delivery modes and between primips and multips. Participants were recruited across 3 geographically diverse US sites, and they were eligible for inclusion if they spoke English, had delivered a live fetus, of any gestational age, any delivery mode, and any parity. Recruitment continued until 300 participants had completed 6-week responses. On recruitment, participants were invited to complete stalk at the inpatient time point and at 2, 6, and 12 weeks postpartum. The outcomes were descriptive summaries of stalk scores and individual domain scores. Frequency of categorical variables were assessed using chi-square test or Fisher's exact test, and continuous variables were compared between groups using ANOVA or Kruskal-Wallis test. A mixed linear effects model was used to compare the stalk score over time using the inpatient time point as a reference score. This figure demonstrates the recruitment and the response rate of the participants, the baseline characteristics. And as Pervez described, there's a whole other lecture to discuss psychometric properties, but to summarize, stalk demonstrated validity, reliability, responsiveness, and feasibility. As for the postpartum recovery profiles, so total stalk scores increased significantly up to 12 weeks postpartum. And diving down into each of the domains, physical health and sleep and fatigue scores improved up to 12 weeks postpartum as well. Whereas mental health and motherhood experience and social support scores improved up to 6 weeks postpartum. We then compared recovery between delivery modes, and there was a significant difference in overall stalk scores at the inpatient time point between delivery modes, with the best scores associated with spontaneous vaginal delivery and the poorest scores associated with operative vaginal delivery. And these differences were driven by differences in physical recovery and sleep and fatigue. At the 2-week time point, there was a significant difference in physical recovery scores, again with spontaneous vaginal delivery demonstrating the best scores and operative vaginal delivery demonstrating the worst scores. When comparing recovery between primips and multips demonstrated better overall recovery up to 6 weeks postpartum compared to primips. This is driven by social support and mental health scores at week 2 and at week 6. And at week 12, there were significant differences in physical recovery scores and mental health scores between primips and multips. To summarize, our study findings demonstrate that recovery continues up to and beyond 6 weeks postpartum, which is really important given that a quarter of the US population returns to work within 10 days of delivery, and this figure increases to over 40% at 6 weeks postpartum. We also found that multips demonstrated better overall recovery compared to primips up to 6 weeks postpartum, and that spontaneous vaginal delivery is associated with better overall recovery and sleep and fatigue at the inpatient time point, and operative vaginal delivery was associated with poorer recovery and sleep and fatigue at the inpatient time point. Similarly, physical recovery was better for spontaneous vaginal deliveries compared to operative vaginal deliveries up to 2 weeks postpartum. So what's the application of stalk? Stalk could be used to identify patients who are scoring poorly and may benefit from improved support and interventions to promote optimal postpartum recovery. Currently, stalk has only been applied in research settings, but we are working with 8 international sites to translate and validate stalk in different languages across 3 continents. And we aim to implement stalk locally at LPCH as we have with OBSCure R10. So next steps would be to implement stalk at LPCH and also to determine the minimal clinically important differences in scores to help inform thresholds or cutoff values at which we may choose to intervene or investigate further for patients who are recovering poorly compared to the others. And then I'll pass over to Pervez. Is that slide?
Thanks, Moe, for a great presentation. I'm going to talk to you just briefly about post-traumatic stress after traumatic childbirth. This is related to a grant that we've just had scored, and Danielle Pinelli is a co-investigator. So what I want to highlight is the fact that this is really underexplored area, but about a third of US mothers, when prospectively asked describe their childbirth as traumatic. And we recently did a 3-week audit where all the patients that delivered at Stanford were screened for anxiety and PTSD. And we actually had a response rate of 98%, thanks to all the hard work of the team. We did this using the post-traumatic checklist DSM-5 survey instruments and the state traits and anxiety inventory. The take-home message here is that 5% of the patients that deliver at LPCH screen positive for PTSD, and a quarter of the patients who had a blood transfusion screen positive, and about 16% of the patients who had a NICU baby screen positive as well. So what we're planning to do is a feasibility study where we're going to recruit across 2 sites. We're just going to screen patients with who have had a severe maternal morbidity diagnosis or a NICU admission, and patients will be randomized to either receive treatment as usual, which is kind of follow-up by the social work team, versus a written exposure therapy, which is a type of cognitive behavioral therapy led by Deborah Kaysen from the psychiatry department. And then there's a new capnometry guided respiratory intervention, which is a breathing intervention, which has shown some promise in war veterans with PTSD. So that's what we're planning to do, and fingers crossed we'll get that study over the line. And what we'll be doing is looking at PCL-5 scores after treatment at 3 months. So watch this space. I just want to briefly mention, I've only got 2 more minutes before we go to questions, but I do want to briefly mention the measurement of sleep. This is something which is an ongoing NIH study where patients are being recruited at Stanford. We know that when we prospectively look for sleep disturbance and sleep disorder symptoms, around 60% of patients in the postpartum period endorse symptoms consistent with insomnia disorder. However, diagnoses are rarely made. Only 2% of patients actually get these diagnoses when you look at large data sets such as the MarketScan or Optum databases. Sleep disorders are very closely linked with postpartum depression, and up until recently, we've not had a decent postpartum specific measure of postpartum sleep. The existing measures don't ask any questions about the baby, which is really important. They don't ask any questions about perineal or incisional pain, maternal protected sleep time, overnight childcare responsibilities, etc., etc. So what we aim to do was, by using PROMIS methodology, which is beyond the scope of this talk, is to really develop and validate a robust new measure of sleep disturbance and sleep-related impairment. This has now been developed, and we're now validating this at Stanford and our other partner sites in this funded study. And the next steps are really to get to the bottom of making some referral guidelines and screening guidelines for postpartum mothers. So who should be screened for their sleep? When should they be screened? And what tools should we use to screen them with? And this potentially, once we answer these questions and develop the guidelines, may also be a nice implementation study that we could introduce across a multi-center setting, and with the primary outcome of looking at referral rates before and after implementation of these guidelines. And then in the future, we'd love to do a treatment study as well, using the patients identified from these screening guidelines. So that's a whistle-stop tour of some of the things that we're working on at the moment. And some of the take-home messages here are that intraoperative breakthrough pain is a real deal for the patients that do experience it, and it happens in around 8% of patients. The psychological sequelae are underexplored, but we're currently actively looking at this. Next, with regards to quality of recovery measures, the OBS-QOR measure is currently being used at LPCH. Please support this initiative and help Team Anesthesia come up with a management plan if patients are scoring less than 65. ERAS implementation is urgently needed in terms of studies to get better levels of evidence across multiple healthcare systems. Chronic pain is a common ailment, and we are looking at seeing if cognitive behavioral therapies improve these experiences. And the Stanford Obstetric Recovery Checklist is the best measure of outpatient recovery, and this potentially could help guide the 6-week follow-up clinic visit. Next, post-traumatic stress disorder after childbirth is occurring in about 5% of our patients. So we really need to determine optimum screening and treatment guidelines. Outpatient postpartum sleep, we've developed new measures which are currently being trialed and validated, and will hopefully result in development of new guidelines for this population. That is everything, and there's lots of people here to thank, and lots of people that have really supported our work. We've also got co-investigators, including Doctors Lyle Carmichael and El Said as well. So it really takes a village to do all of these things. So I'm very appreciative of everyone's help, and I'm happy to take any questions as well if anyone has any.
Great. Yeah, Pravez, thank you so much for a fabulous presentation, and also to Moe and Philip. There are a lot of questions in chat. We have just about 4 minutes to get through them. So
Okay.
try to ask them efficiently, and maybe we can just go for quick answers right now. But the first two are related. So first, there are lots of kudos, but you can look at those later. The first two are related, and essentially a question around why ethnic background and spoken language is a significant variable for the experience of pain. Is there, is this a cultural expectation? But related to that is, and asked to talk more about the racial and ethnic disparities of pain during cesarean delivery.
It's a great question, and it's one that really is so relevant to our practice. And as a provider in the anaesthetic room, I feel so much more comfortable if the patient speaks the same language as me. As soon as you have a iPad interpreter, then in a busy, loud OR, I feel a disconnect with my patient, and there's no way that the patient's rapport that I have with the patient will be as good. And I think that is one of the main things that is driving this. We have to think about the patients that are experiencing pain but don't feel comfortable to speak up. And that actually is a theme that came up in some of the interviews that Dr. Callahan did. That decision making for the patients of, okay, I'm feeling something, but they said that I'd feel something, so I'm going to let this slide. So there's a certain threshold that someone has to experience pain before they actually speak up. And that may be different if you don't speak the same language as your provider, or if you're using a interpreter as a middle person. But the truth is, we actually don't know the reasons. In the UK, from our multi-center study, we actually found that pain outcomes were worse at day 30 in Asian patients. So there may actually be cultural and genetic differences in different populations as well, but these are underexplored.
Okay. And then some of this, and maybe I shouldn't couple these entirely, because some is well beyond language. So can you comment separately then about racial and ethnic disparities in pain during cesarean? So let's just say where there's language concordance, there's not the issue of a different language.
Yeah, so that
we see that repetitively.
Yeah, this has been well described in the literature with providers, having implicit biases in their practices, thinking that certain races of patients have higher or different pain tolerances. But yeah, within the cesarean delivery setting, during their cesarean delivery and pain experiences, it's really underexplored. So we need to get to the bottom of exactly what's going on there.
Okay, and then there are a couple of questions I'll link around STORK and the STORK score. So one is if you were able to stratify the non-scheduled cesarean delivery by stage of labor. For example, if there's a second stage cesarean, or if you're looking at operative vaginal delivery, the true alternative is a second stage cesarean. It's not a vaginal birth. And so could you compare those two, and have you been able to do that? And then I'll get to the second STORK question.
Yeah, it's a fantastic idea, and I think that's something that we should definitely look at. We haven't looked at that yet, but I think using STORK, it just opens up so many different study ideas, and we're trying to get through them. But if anyone's interested in collaborating, we would love to have OBs on board and driving these projects as well.
Great. And then regard to STORK, Amanda Williams is asking, with regard to the STORK survey from a health systems perspective, when would it be most impactful to look at patients needing additional support? So thinking about this from just postpartum, what from all that you know and all that you've seen, where would you put your resources?
So I think that if we can identify patients not recovering well earlier than 6 weeks, that would really be of benefit to patients. A recurrent thing that I found when I was interviewing, particularly first-time mothers, was that they wished they had more input and support and resources in that first 6 weeks. So I think in the first week, there tends to be a lot of adjustment going on at the home. So there's not such good engagement in terms of response rates, but that picks up massively at week 2. So I think that week 2 probably would be the best time. And then that gives us an opportunity to deliver early targeted interventions as well, where we can maybe even see the trajectories of stalk change for patients who are randomized to interventions.
And then related to that on timing, Elliot Main is asking about the most appropriate time to assess for PTSD. He said that his impression is that you want to wait a few weeks or longer after a traumatic event, because we do know that those scores in a lot of these domains do change over time.
Yeah, it's a great question. And to be honest, we actually don't know the best time to screen. So one of the reasons why we wanted to do the study was to see what the prevalence was at Stanford. It's probably a bit low to offer universal screening because it's quite time and labor intensive. But yeah, at the same time, Dr. Kaysen has educated me and taught me that actually the natural progression of PTSD symptoms is to improve over time. But in the same way that if someone has a post-jaw puncture headache, the natural course is to improve over time. But if you offer a blood patch, you can actually improve the course of the recovery and trajectory. So by identifying patients early, maybe we can improve the trajectories of how quickly those PTSD symptoms resolve. But the jury's still out there.
Great. And we are over time. I just want to indulge in one final here. Is just someone is asking about the role of AI in optimization. It just seems that there are many metrics with different approaches to assess postpartum recovery. Do you see any role for that? I mean, or have you thought about what that role might look like at this point?
Yeah, we're very privileged to have the access to 14 years worth of our EPIC data through a data science initiative with the Department of Anesthesia. So we actually have that data. So we could quite easily do some machine learning modeling to identify risk factors and to maybe even flag people real time. I'd love to do something like that going forward for sure.
Great. Well, thank you all for this fantastic presentation, and thank you to our 34 audience members who have hung on a little bit late, but this is really wonderful, and lots of good things ahead, and I think you've given a lot of people many ideas too, and also really planted the seeds for all this great work that's happening now. Thank you all.
Great, thank you.